Hello, everybody. We will wait for a few more seconds so more people can join and then officially start the webinar. Okay, let's get started. Hello again. Thank you for joining us. This is the last webinar in the series titled Community-Focused Approaches to Mental Health and Resilience, hosted by Kian Foundation. Today, we are privileged to have Dr. John Drury as our guest to conclude the series. I will start with a quick introduction about series and how you can get access to the previous webinars and the recording of this one, as well as our goals to develop this series. And then I pass the podium to Dr. Drury. Kian Foundation is a nonprofit organization registered in the United States with the main goal of promoting health and human rights for people in crisis. Kian Foundation was initiated in support of the Women Life Freedom movement in Iran and is named after Kian Pirfalek, an amazing 10-year-old boy who was killed over the Women Life Freedom protests in Iran. The mission of the Kian Foundation is to promote health and human rights for people in crisis worldwide through education, empowerment, advocacy, and support. We developed a series to address different aspects of social and community resilience, facing adversities and social traumas in situations that are dealing with crisis. Today, we have Dr. John Drury, a professor of social psychology at the University of Sussex, as our presenter. Dr. Drury's research focuses on collective behavior in emergencies, collective action, and live events. He developed the social identity model of collective resilience, which explains cooperative behavior in emergencies, disasters, and other threat situations. His research has informed the UK Civil Contingencies Secretariat, National Risk Assessment, UK Government Guidance on Communication Crisis, UK Fire and Rescue Serving Training, and other initiatives around the world. He is a part of the UK SAGE initiative as well as Independent SAGE, which I am a big fan of. And he currently sits on the Cabinet Office Behavioral Science Expert Group. And his topic is about the psychology of collective resilience, crisis, and their aftermath. So without further ado, I pass the podium to Dr. Drury.
Thanks very much, Reza. So we typically think of communities and hence community resilience in terms of a group of people who have established connections to each other, maybe through living in the same place or being part of a network. But in this presentation, I'm going to describe research on communities that arise spontaneously in emergencies and other crises. I'm going to explain some of the psychology of these spontaneous communities, which is based on the concept of social identity. So I'm going to talk about research in three areas and resilience in three areas. I'm going to talk about emergency response, how people actually behave within an emergency, and contrast our current understanding of resilience processes in these situations to the older understanding of human behavior in these circumstances as psychologically vulnerable and fragile. Secondly, I'm going to talk about some research on the aftermath of disasters where people who have been connected by the emergency continue to support each other through informal groups and help each other through the difficult recovery period. And finally, I'm going to describe some recent research looking at COVID mutual aid groups and what can be done to support and sustain those groups over time, because like many of these spontaneous groups, they arise in a time of crisis and they tend to decline over time. So what can be done to sustain them, given that they are good for people's survival and their mental health and well-being? So first of all, then, let's talk about how people behave in emergencies. What do people actually do in emergencies? Well, for years, there was an emphasis in academic psychology and disaster research on psychological vulnerability. People tended towards panic. That was the argument. They lost control of their behavior. Uh, Emotions spread easily through the crowd, um, and it was a kind of chaotic response. Um, Research since then has established, well, pushing and shoving does occur as people try to evacuate. It usually doesn't spread. Most people do not lose control of their behavior. And cooperation and social support is remarkably common during emergencies. And I think that is one of the strongest arguments against the assumption that people in crowds automatically lose control of their behavior and become competitive. Not every person, not every emergency, but it's been observed so many times in the literature that it's kind of well established now. I've got on the slide there two disasters, two crushing disasters. And the reason I've got those on the slide is because these are events where, as you can probably imagine, it was very physically difficult for those affected to help each other because people didn't have the space to physically move their bodies. But you can see in the Hillsborough example, some people were given help by others in the event. And we interviewed people at that disaster. And there was a great study by a sociologist, Norris Johnson, of the Who concert disaster. And in both of these cases, there were many examples of people, the survivors, who described their desire, their attempt to try to help other people. So it makes the point that even where it's very difficult physically to try to give support, help to others affected in an emergency, there is that impulse. It's such a strong impulse that it manifests itself even in very, very difficult situations. I mean, it could go even further than this. I mean, Charles Fritz, as one of the early sociologists studying behavior in emergencies and disasters. And he made a strong claim that most of the initial search, rescue, and relief activities following a disaster are undertaken by disaster victims themselves before the arrival of organized outside aid. And I think, in a way, there's official recognition of this now. I mean, in the UK, we have a whole program, a government program called Community Resilience, which is based on the assumption that the public are going to get there first and give the support before the professionals do. Pictured on the slide there is a recent book that I was involved in editing, and there's a section in the book that brings together some of the work looking at public responses, public cooperative responses in emergencies across a range of different types of incident. So now I want to tell you about one particular study that led me down this way of thinking, really, I suppose. About 20 years ago now, there was a terrorist attack on the London Underground and a London bus. Over 50 people were killed, over 700 people were injured. And the people affected, that the survivors, were left underground. They were trapped underground for a period of time. The emergency service didn't get to them, couldn't communicate with them, so they really were left to themselves to deal with their situation for a period of time. So we interviewed survivors, and we had access to a very large number of testimonies from survivors too through the official inquiry. Very harrowing stories of what people did and what they saw, and so on. And our first question was, well, do people report help? Do they observe helping behavior? Did they observe helping behavior in others? Did they participate in it? Did they receive it? Or did they talk about selfish behavior? And when I refer to helping behavior here, I'm referring to it very broadly. So not just kind of expert help like tying tourniquets, which did happen, but also very seemingly mundane forms of assistance, like sharing a bottle of water or giving emotional support, such as reassurance. So I'm covering a full range here. And you can see on the pie chart, I think, whether it's people reporting help they engaged in or saw or received, that outnumbers the number of reported instances of selfish behavior, which included people ignoring others who were asking for help. I've got a nice example here of one of our interviewees describing his experience of this. I'll just give you a second to read that. See, what I like about this quote, I mean, there's a number of things. First of all, I think it makes the point very strongly that the kind of assistance that people often need in emergency evacuations is often not the heroic help that we might think of in these situations. You know, it's not requiring expert help. It's actually requiring something more like cooperation or coordination or even solidarity, right? So somebody just allowing him to go first rather than competing with him for space as they filed out. That's really, really important, because in emergencies like this, and 9/11 is another very good example, most people who survive because they simply coordinated their egress, their evacuation in an orderly way. The other thing I like about this quote is you can see he's emotionally touched by that gesture, if you like, by the other person, the kindness, the concern, the respect, the politeness of that other person who allows him to go first. He's touched by that. And why that's significant is because we know that emotional support helps people in times like this, and it helps in the recovery. And that's something I'll be coming back to in a bit later. So that finding that people were, I mean, you know, you might argue that it's overstated, that people weren't willing to disclose their selfish behavior, possibly, but the pattern we uncovered there looks very similar to previous research by other people. And the question is why? Why are people so helpful to others during an emergency? Because you might think, well, actually, you might want to just look after your own safety and get out as quickly as possible. All the time you delay your exit to help others, you might be putting yourself at risk. So we looked at people's experience and, well, whether they felt in danger, first of all. So it could be that people were helping others simply because they felt they weren't in danger themselves now. The bomb had gone off. If you look at the first row of the table there, you'll see that most people who talked about it, look at the first row and the second row, most people who talked about it felt that they were still in danger after the bomb had gone off. Because of course you would, right? A bomb exploding shatters your worldview, right? You no longer feel safe. And people describe this in quite clear graphic terms. They said, well, I thought there might be a secondary device. I thought the tunnel might collapse. I thought we might get hit by another train. I thought I might stand on an electrified rail. But still, people helped, even though they felt in danger of death. In the third row, we were interested in whether the reason that people helped each other so much might have been because they were already with people they knew. And this is, you know, the more standard idea of community resilience, which is that you have a network of people who you've already got a relationship with, you've invested in that relationship, and these people are the ones that help you and you help in an emergency. Well, these bombings took place during rush hour. People were on their way to work. People were not with people they knew, and hence most of the people we heard from were not with friends or family. They were with strangers, and still they helped. So we started looking then in the search for an explanation at people's, how did people see the people they were with, the people that were around them? And anyone who's ever been on the London Underground and at a normal time will speak a bit like our interviewee when we said to him, well, how did you feel, before the bomb went off? Did you feel any sense of unity with the people around you? And he said, well, no, of course not. I didn't feel unity. I just wanted to get from A to B. I just wanted to get a seat. So psychologically speaking, we would understand this as the person thinking in terms of their personal identity. I'm just thinking about me as an individual. Um, I don't feel connected to the rest of the people here. I don't feel part of a group with them. So psychologically, they're a me in relation to other individuals. So when we asked the same question again about their experience immediately after the bomb had gone off, interviewees responded with a rich vocabulary of we-ness. They talked about a unity, a togetherness, a similarity, affinity, being part of a group. Everybody, didn't matter what color or nationality, you thought these people knew each other. Teamness, warmness, vague solidity, empathy. So what seems to be going on there is that people have now shifted. There's a shift from just seeing yourself as an individual to seeing yourself as part of a group. And our argument was that this group existed as a function of the relationship of the group of people as a whole to the bomb. The contrast between the bomb blast and the people affected by the bomb blast created a group. So we found some evidence for that analysis too in looking at the numbers, because people, we call that a common fate, the way that people are grouped together, and people used phrases like "we're all in the same boat now." So a number of them did talk in that way. And a number of them did talk about this sense of unity. And much fewer of them talked about a sense of disunity. So a new sense of unity, which we take as evidence of a shared social identity, by which I mean the sense of yourself as a group member you get from being a part of that group. So seeing themselves as a group member arose from that sense of common fate. And on the basis of that study and a number of other studies, some of which are listed at the bottom of the slide there, earthquakes, floods, and other disasters, we developed this model, and it's a model of how this sense of being part of a group, this shared social identity, arises spontaneously in an emergency incident, through the sense of common fate. People feel grouped together. And when you feel part of a group with other people, it affects your motivations towards them. It affects your expectations of them too. You will feel more motivated to assist them, because they're an us, they're part of a we. So what happens to them, you feel that, you care about that. The boundaries of your concern are extended to include them. So hence, when people share social identity, the more that they share social identity, the more that they will be motivated to provide support, to cooperate. And as I said, they will also expect others to support them, because I am part of your group. So therefore, you will care what happens to me. And when people anticipate others' actions, it makes it easier for them to coordinate, to act as one. And get a sense of confidence, and that sense of confidence in their actions is often associated with well-being, and that is why well-being is on the slide there too. So that was an early study in this program of work that led to this way of thinking of groups as emerging as a social identity process within emergencies and disasters. But of course, we also need to think about the recovery period, and after emergencies and disasters. And we know from much of the literature that social support that people receive after an emergency or disaster or a major incident contributes to their well-being over time, helps them recover, helps reduce the likelihood of them getting psychiatric symptoms. So taking on board the work on these groups within emergencies, we wanted to ask in another program of work whether the same kind of groupness, these groups of survivors themselves, could play a role in giving beneficial support after the event. And the incident I want to tell you about next is it's another terrorist incident. It's the Manchester Arena bombing, which took place in 2017. So what happened then was a suicide bomber again blew themselves up in the foyer of the Manchester Arena just as the pop star Ariana Grande was finishing her concert. And as you probably know, that she's a pop star that attracts lots of children and young people. So the blast killed 23 people, including the bomber, injured hundreds more. Many people were distressed too. I mean, many people attended the event. Thousands attended the event, a very big event. So many people injured, many more people distressed by what happened afterwards. And so this is a program of work I was involved with. It was led by a colleague, Richard Williams, as well as people at the Manchester Resilience Hub. And we know, actually, even though people talk about trauma quite a lot, we know that most people who survive terrorist attacks suffer distress. They don't typically go on to suffer conditions requiring specialist mental health treatment. There's a distinction there. So you've got many people suffering distress, a minority with psychiatric symptoms. So they're not getting up to psychiatric thresholds, but they're still struggling and they're still distressed. And these are the majority. And these are the people that we're concerned with here, the people that might not have come to a psychiatrist but are still suffering. So this piece of research had a number of questions. I'm just going to talk about part of the work. So first of all, we wanted to know, was there any informal support seeking amongst survivors, and what kind of provision did they get? So this is, anything outside of going to formal sources of support, like their doctor or therapists or whatever. So who provided the support and how did it help? In what way did it help? And if people formed support groups, like peer support groups, which sometimes happened, and they became part of peer support groups, did that help them or did that hold them back by focusing on the incidents and the trauma, or was it forming a kind of springboard to going forward from the distressing, upsetting, traumatic incident? So for the first part of this program of work, we interviewed a small number of survivors, and the criteria were these were adults and they were not physically injured. And you can see the publication that I'm going to, the publication that came out of this work. So what we found that much of the psychosocial care received by people was informal. So people very often didn't go for formal support. They simply tried to get support from their families, from their friends, from their peer groups, from their social networks. It was common to try to get this kind of support. And in terms of what that support was, or what they tried to get from these friends and family and networks and so on, was they simply tried to share their feelings. They tried to talk about how they felt. But they also felt constrained from doing so with friends and family who hadn't been at the incident, with people who they perceived were not able to understand what had happened to them. But not only that, they also got the sense, and a number of people described this, that the friends and family members kind of it was a burden to them. It was an imposition to kind of hear this. So somebody says, I don't like being a burden. I'm quite self-sufficient and independent. I don't like that whole showing signs of weakness, being upset in front of people, even though it's not a good thing to do. That's how I am as a person. I kind of bottle it up. It didn't do me any favors at the beginning. And if it happened again, I wouldn't burden people again, because I feel people have got their own things going on. So that's it not going so well. But all interviewees also described forms of interaction, conversation, discussion, informal social support that did go well. And one process that seemed to be helpful to them was what we call validation, where they did share their feelings, and the people they shared it with understood, sympathized, validated, said, yes, I understand what you're going through. And this was a response, a reaction that was particularly evident in these peer support groups with people who had the same experience, people who had been at the Manchester Arena as well, and sometimes people who'd been at other incidents. I think you've got to have been there to understand, which is why that group was really good, because they all said the same. Family are sympathetic. They're there for you. They do whatever they can, whatever you want them to do. And if you're upset, they will try and comfort you and things like that. But they get frustrated because they don't understand how you feel or why you feel like you do. And so our other question, as I mentioned, was whether these groups could held people back, make people focus too much on the trauma, or whether they enabled people to go beyond the distressing experience and build new relationships. One or two people mentioned, yes, I was worried that the group would dwell on the trauma, but then they went on to describe how the group had provided a springboard to new relationships and what sounded like personal growth. The groups are really good because you felt like you weren't going mad by being there. And other people would be like, no, I'm like that as well. They were so useful. I'm still in touch with two of them that went now, and we meet up now and again for a coffee, and the children come and they get on as well. And so, yeah, it was really, really good. So notice this person is talking about these groups in the past. So now he's fine. He doesn't need the group anymore, but he's got new friendship, or he or she has got new friendships from the group. So as well as doing these interviews, we also did a small survey, and you can see, numbers are pretty small. People don't always want to come forward to describe their experiences for these kinds of incidents, of course. So a small cross-sectional survey, and like the interviews, these were carried out quite a long time after the incident, 3 years after the incident. And in the survey, we had a small number of variables, and I sort of want to describe a key pattern in the findings, which is depicted in this figure. I want to tell you first, however, that we asked people about different kinds of help, and on average, people were saying that the support they got from other arena survivors there's more of that than there was from people's friends or family or workplace. So what this figure describes is the way that social identity on the left there, so people's sense of being in a group with other arena survivors, it's social identity with other arena survivors. It was associated with support. So it looks as if the more support that people were getting from arena survivors, the more that they identified with that group. So this is 3 years on, remember. So, presumably that sense of being part of that group was something which arose in the event. But, 3 years on, what's sustaining it is the support they're getting from fellow group members. Social identity with other group members predicts sense of efficacy, and that is a very well-established association, lots of literature showing that association. And efficacy predicts current mental well-being on a well-established scale. And again, the relationship between efficacy and well-being is well known too. So anyway, that survey, I think, demonstrates the role of being part of these kinds of groups is associated. I mean, we can't say it's causal in this kind of evidence, but it is strongly associated with later mental health benefits. And this work, of course, it's not purely academic. It's we did work with the NHS. It was an NHS hub who were collaborators. And Richard Williams, who was leading the project, was asked to lead a memorandum, some advice for the National Health Service in the UK. And I just want to let you know one of the recommendations. It's the one that I made in the report, which is if we think these informal groups of survivors, these peer support groups of survivors who find each other through the emergency, and what they've got in common is just the emergency incident itself. How do they find each other afterwards? Unless the health service, the organization helps them, they might not find each other, because the NHS hub was a place where people came to, and it had the capacity to bring people together and say, well, here's a list of people who want to meet up with each other. So it should do that. It should facilitate that connectedness. It should use its knowledge and its capacities and its resources to facilitate these groups, because it's not easy for them to get together and find each other otherwise. So the final example I want to talk to you about is a different one again. And so this is a very different kind. I'd say this is a disaster. It was an emergency. It is a disaster, the pandemic. And one of the most fascinating things about certainly the initial stages of the pandemic was the rise of mutual aid groups. I don't know whether in your countries you had the same thing. We had them in the UK. Many other countries had them, and particularly in those countries where there was not wraparound state support, where the government basically said, "Okay, you need to stay at home to everybody, and it's up to you to organize yourselves and sort yourselves out." So if you are having to remain at home because you are self-isolating, who will do your shopping? The government is not going to do it. Who will do it? And it turned out it wasn't just family and friends, it was your neighbors. Your neighbors organized themselves into these groups, and they called themselves mutual aid groups. So they weren't the established charity groups. They weren't the established non-governmental organizations. They were just informal groups of neighbors who set up a WhatsApp group or something like that, and said, and maybe started knocking on doors and said, "Do you need any shopping?" And at the time, commentators said these were absolutely essential. And I think most people felt that these were essential. They did allow people who otherwise would have struggled to self-isolate to do so. So they rose very quickly. Thousands of them arose at the start of the pandemic. But one of the things we know from looking at other disasters is that what might be called altruistic communities, these spontaneous groups in the community that arise to give each other support at the time of crisis. One of the things we know from the great work of Chris Kaniasti is that these decline. They decline quite quickly, really. I think Kaniasti puts it at about 2 months. 2 months after the incident, they're in sharp decline. They run out of energy. They run out of resources. People get burnt out because all the energy they're using, and sometimes the state comes in and kind of takes over and disempowers them. And I've got some pictures of a flood up there because it's such a good example. Because six to 12 months on from the flood itself, many people are still struggling to rebuild their homes, and they become isolated again because the group that arose at the time of the acute crisis is not there anymore. So they're needed. They're still needed. And the same can be said about COVID, of course. And, just as Chris Caniasti said, if you look at the dark line, the big spike there, the big spike at the beginning, that's a rise of COVID mutual aid groups. We mapped this on hundreds of Facebook groups in early 2020. The grey line at the bottom is the infection rate, and I think it's understated at the beginning because it wasn't counted consistently. But you can see towards the end of 2020, in the autumn, when COVID spiked again, the mutual aid groups they still existed. You can see there's still the black line there. Some of them were still active, or some people in them were still active. They were still going, but nowhere near the early days. But they didn't match the need. They didn't match the demands. So they needed, so this project I want to tell you finally about looked at the question of how they can be sustained. How when after the immediate impact of the disaster, months down the line, how can the group be sustained? We got some ideas for the answer to that question from Evangelos Tontis's study of the York floods in 2015, because he found that the people who were more active in the community, the ones who tried to keep the group going, what they did was they just meet and they just have conversations about the group. So it helped them to have a place to meet. They also tried to organize commemorative events to bring back the memory of the group and bring people together. So they tried things. So our work on the COVID mutual aid groups used a number of different research methods. We reviewed evidence on volunteering. We interviewed organisers. We interviewed volunteers. We did a big panel survey. And it was an element of co-production because we had COVID mutual aid group members and organisers in an advisory group with us. So when we spoke to organisers, we said, well, what kind of things would allow you to continue, keep going forward? And many of the answers were very practical. They weren't really psychological at all. Well, we need to know how to apply for funds, how to apply for grants. We don't know. We're just amateurs. What about a salary for the organisers? We need things like storage space. If we're going to distribute shopping and food and resources, we need somewhere to store it. We haven't got that. We need transport. We need a meeting space. We need better connections with voluntary organizations who could help us with these things. So lots of practical things. But some of these answers raised attention. Something like, for example, the salary for organizers, right? There's a tension there because the attraction of mutual aid groups, both to participants and to the members of the public that used them, their community members and their neighbours that used them, was their independence, their grassroots nature. These were not the professional charities. These were not the established NGOs. These were just your neighbours. Okay, so to professionalize them by becoming an official charity, by having a salary, that would conflict with that identity they had as grassroots groups. Which is why the partnership with the official groups who would have the resources, have the connections, have the bank accounts, might be a better solution for them than trying to become one of those charities themselves. But psychological elements were important in another way because the organisers also talked about the way they tried to get volunteers to feel a part of the group. So the way that they said we sustain commitment in our volunteers, we keep the group going, is we try to make them feel a part of the group. And we try to make the group feel a part of the community. We think about our volunteers' well-being. We have, our own kind of health and safety. We don't want them to get ill. We try to give them skills. We try to empower them. So they talked about various strategies they employed to try to embed their volunteers in the group and to get them to feel part of the group, including organising meetings, having good communication, having a horizontal organization, so it wasn't too hierarchical. And the one I want to talk to you about is promoting a culture of group care. So not just caring about the individual volunteers, but having a whole culture whereby it was seen as, one of the values of the group. So quite a few of our organizer interviewees talked in this way. They gave examples of distributing the workload fairly, giving emotional support, guidelines to protect volunteers. So, for example, Emma says, I think support and teamwork explains a lot. I think doing this kind of thing, especially doing it now, working from home, you need a good team around you. You need that support, that motivation and that encouragement. So I think because we've had that, it supported us, it supported the volunteers and gave them reassurance as well. So it sounds like a lot of emotional support. So when we ran the big questionnaire survey that I mentioned across 2 waves, it enabled us. One of the things we could do was test whether doing this culture of care actually worked. Did it make people feel part of the group? Did it embed people in the values of the group? Did it lead them to carry on participating? I have to say that the evidence is not brilliant, but there is some evidence of it working perhaps. So first of all, just looking at the correlations, there was certainly a correlation between volunteers saying, yes, there was a lot of group care in the group I was a part of, and my identification with the group. And both of these variables also correlated with future participation intentions. So that looks fine. But when we looked at it longitudinally across the 2 waves, the evidence was not quite so strong. So at time 1, when people said there was a lot of group care in the group, there's a value of group care, it predicted the time 2 sense of community responsibility. So it did seem to embed them in the group. And community responsibility was a predictor of future participation at time 2. So some evidence that they are related in the way that the organisers hope. So I'm coming to the end, so let me give some conclusions for all these studies and ideas I've been talking about. So we talk about resilience and community resilience quite a lot, but I've been talking about collective psychosocial resilience in spontaneous groups. And I'm saying that it's not really a thing. I see it as a process, and it's a process that's commonly found in emergencies. I said in the second study that in informal survivor groups, so the group people that come out of an incident, sometimes want to get together and share their experiences, and in doing so, they can provide each other with mutual social support, which helps people cope in the recovery period. And finally, I talked about COVID mutual aid groups, who are groups trying to help the more vulnerable in a situation like a pandemic. And these are quite difficult to sustain over time, like all spontaneous emergent groups in disasters and emergencies, but they can be scaffolded and sustained by their relationships with other groups like charities who have resources, but also by strategies such as a culture of care to build the sense of commitment among volunteers. So this is not just my work, this is the work also of a large number of colleagues, so their names are listed there. And this is me and some of my links, and thanks very much.
Thank you very much, Dr. Drury. This was amazing talk. I have quite a lot of questions, and there's one question in chat. I try to rephrase the question in a way that kind of inject my own question into that. So the comment is, I love the first world strategies in response to disasters. I am lucky to live in one. I'm interested in ways on how we can implement them in other parts of the world with less resources and rough government. So Basically, I had more or less the same question, more around the notion of external support, or basically establishment or governmental support to sustain these groups or to build collective resilience beyond spontaneous social network activities that could be done. So how critical are those? And in situations like the current situation in Iran, that we cannot count on those governmental support, how we can sustain those movements?
Yeah, I can see the problem. Although, I don't think, and I'm not saying either, that the COVID mutual aid groups got a lot of government support here. They didn't really. They asked for it. They asked for it, but they didn't. I mean, I suppose the closest thing was that some of them had good relationships with local authorities, local councils. Some of them did, but for others, they were hostile to the local authority, right? I mean, you might know that the name mutual aid has got a bit of a history, and its history is anarchism. That's where the phrase comes from. And so, of course, not everybody getting involved in these groups were anarchists, but there was certainly a tendency in those groups. And so a lot of them, they weren't actually seeking help from the state. They were hostile to the local authority because the local authority was seen as controlling them. Um, but the downside of that is they haven't got the resources then. They've run out of resources. They haven't got physical space. They haven't got transport. Councils have things like, oh, yes, we have a place where you can store your equipment. We can lend you printing facilities. Um, and so they weren't able to get those things. The only way to get them was by getting donations in the community again. The better off in the community would help the less well off in the community. So, I would say these examples are not really, I mean, you have complaints from people going all the way back to the London bombings. I do remember after the London bombings, some of the survivors there tried to set up a group and they complained. There was a complaint that the states haven't supported us. Why hasn't the state come in and enabled us to be this group? So it is a common complaint. So either people ask for it and don't get it, or they're rejecting it anyway for ideological reasons.
Thank you. Nima, I see you turned on your video. Do you have a question?
No, no, no.
Yeah, so I have a question about the notion of common experience and how people got related to the people with the common experience. How exclusive this common experience should be. So like people in the same incident, or people with a history of trauma, or people living in oppressive settings. So like, again, based on your experience, how should this arrangement of people in the same group work?
Yeah, it's a great question. I mean, the idea is based on self-categorization theory. If you look at some of the criteria for self-categorization, one of them is a common fate or comparative fit, that the similarities within a group are greater than the differences between a group and another entity. Right? It's the same idea. I mean, John Turner talked about common fate as, he said, it's not a direct relationship between common fate and things like cooperation, right? It's an indirect thing. Common fate is one of the possible criteria for people seeing themselves as a group. So, I mean, the basic self-cat idea is quite, well, it's an interaction between affordances and our cognitions. But there's another dimension to it, and your example is a nice one because you can also argue, couldn't you? You can argue, right? You can say, well, look, we're all in the same boat, right? If you're rhetorically declaring that, you can extend the boundaries, can't you? You're not just at the mercy of the affordances of the physical context. You can also strategically argue that it's more than this. Look, we're all, it's everybody affected by these kinds of incidents. We're all in this group, right? And to promote that shared social identity as a strategy, that can be done too.
Thank you. So it could be transformed into intervention. So how we can frame it and how we can package it as a shared experience.
Well, there's different ways of creating a shared identity, and I think common fate is one of them. But the key hinge really is the shared social identity. That's doing all the work, and there are different ways that shared social identity can arise. And one is we find ourselves in the same boat.
Mm.
Another one might be, the common history. Another one might be intergroup comparison, and so forth.
Thank you. Nima, I see you raised hand.
I have a question. You mentioned during your talk, John, about the fact that most of the helps that non-governmental organizations mentioned was not psychological. That was part of it, which I think is very important. And the other thing that you mentioned is that not all the trauma uh, uh, goes into the category of psychiatry, that people need to seek psychiatric help. Again, it's very important to me. I just want to know about your experience in terms of seeing psychologization of these facts, events, or whatever you like, in a sense that maybe I'm wrong, correct me if I'm wrong. What I see in psychologists community, generally speaking, is psychologization the issue instead of looking at not just the psychological part of it, but also at other parts. When you look at psychology in general, do you see that kind of trend in the UK or other countries that you collected data?
Before I come to that, yeah, something else your question raised. I mean, like when we think of trauma, I mean, trauma is now part of everyday discourse, isn't it?
That's
Right?
right.
It's not just the specialists that use this. And Richard Williams and I are quite reluctant to use that term quite a lot, but I can really understand why everyday people use it. Right. So one of the incidents we've looked at over the years is the Grenfell Tower fire. Okay, and my PhD student led some research on that, and people living in the area of Grenfell talked about trauma, not just the survivors, people living in the area. And why were they doing that? They were doing that as a warrant for justice, as a warrant for compensation, right? So, you can't, if they had said, I'm not traumatized, then society would minimize and would be able to push back against their claims for compensation, for justice, and so on. So it becomes part of that argument. So it's quite, even though as a psychologist, as someone looking at distress, I would say, well, you've got PTSD and that's a thing, and then you've got distressing experiences. But in arguments, right? Because a lot of it exists in struggle, doesn't it? In struggles, people talk about trauma. And on your question of is kind of psychology in my country and the US very psychologizing of incidents like this? Uh, I don't know. I don't work in clinical psychology. I work in social psychology, and so I suppose we might be less guilty of that. Um, and I'm not so embedded in debates in clinical psychology. Um, but
That
I
makes
suppose if I think of one recent example it reminds me of, though, is COVID again, because if you try to analyze the pattern of illness, the pattern of severe illness, the pattern of mortality, um, then and long COVID too, there's a class basis to it. And who are the people getting exposed to illness? Who are the people more likely to be vulnerable to illness? And there's a class basis to it, and it can't just be reduced to individuals because there's a social gradient that explains those patterns. But that's a recent example. Other than that, I'm not sure.
Hmm. I just want to pick on that, the first part of your answer to my question, which I think it's very fascinating to me, that psychological labels in one way is a way that we can validate our experiences, our distresses, but at the same time, it seems that there is no other non-psychiatric, non-psychological language to use to validate these experiences. As soon as we use these labels, then we kind of pushed even though we don't want to be pushed, but we pushed into the psychological and psychiatric discourses that we need to go to a psychiatrist or to get a drug or something like that. It's very fascinating to me that this is like a double-edged sword.
Yeah. No, I think that's the risk. Yeah.
Thank you. I have another question, and I think that will be the last one, given our time. So, so like the talk is more around the notion of acute emergencies, and I understand it makes sense that the common fate and common identity shapes around the acute emergencies, but many adversities are more chronic over the long term, and there is no specific emergency to point into, but people have the shared experience. The idea of the same boat applies to that, and the concept of collective resilience could be applicable. So how are the dynamics of chronic adversities different from emergencies and acute events?
Yeah. Have you got an example in mind?
Sure. So poverty, here we have basically different, like in the United States, we have different epidemics, like behavioral epidemics, we have like drug epidemics, etc., that would affect a community with the shame, with the shared experience and shared adversities. In the context of Iran, again, we have living in a chronic situation of under an oppressive government, an oppressive situation, with all those traumas, small and large traumas that happen all together, and we all share when we talk, and I understand that when we talk together, we can find common, basically memories and common experiences. So the idea of common identity and common fate comes into action, but the process of collective resilience, I assume, would be a little bit different. So there is a comment here in the Q&A about how the diversities and differences come into play when the situation is not as urgent. So, and we experienced that. So when the crisis was more acute and more fresh, people were more likely to be together, or the idea of common fate would more be in place. But now,
Yeah.
since the situation is becoming more chronic, differences are appearing, and the idea of common fate is kind of disappearing.
Well, yeah, but also the other thing is, have they got the resources anyway? Because it's not just, I mean, you might have the motivation, right? So to the extent that you see yourself as a group, we're all in the same group, then you feel motivated to care for others. But if you're talking about poverty and drug addiction, then people are likely not to have the resources to do that, and not likely to have the energy to do that. So it is different, but also you're also talking about stigmatized identity to some degree, aren't you? Like poverty and drug addiction. I mean, one of the features of these emergent groups, like at bombings, is they haven't got a history, right? They haven't got a content, right? They're not a typical social identity. And if you think of social identity, you think of, I don't know, being British or Manchester United supporter, or it's a category that's got a history, or it's an opinion-based group. We're not talking about that. We're talking about an empty category, really, and that it's a very situation-specific empty category. Certainly not stigmatized. We're talking about stigmatized groups. You're going to have to do some work there political work, strategic work to reclaim that group. So I don't think it is the same. No, it's much more fragile, contingent. It won't happen unless somebody kind of drives it for those groups. So it becomes much more a strategic political thing, building a campaign around poverty, building a campaign around drug addiction, rather than groups automatically, because they objectively in the same group, seeing themselves in the group. They're not going to, I don't think, unless somebody does something about it.
Thank you so much. We are at the cap of the talk. I want to especially thank you, Dr. Drury, for this great talk, and for the participants. I shared the link to our YouTube channel that you can find the recording of this talk as well as the previous ones for you later use. I want to thank everybody for attending, and I hope we see you again in our next series. Thanks
Thank
very
you, John.
much, and have a great day. Thank you.
Thanks very much.